Anal canal is the terminal part of the gastrointestinal tract situated below the level of the pelvic diaphragm. Here, this is the anal canal. It is basically lying in the anal triangle of the perineum between the right and the left ischioanal fossae, which is allowing its expansion during the passage of the feces. The saculations and the tinea are absent here as well. Now, the anal canal is 3.8 centimeter long, extending from the anorectal junction to the anus, directed downwards and backwards. The anal canal surrounded by inner involuntary and outer voluntary sphincters that are helpful in keeping the lumen closed and in the form of an anterior posterior slit. The anorectal junction is marked by the forward convexity of the perineal flexure, this perineal flexure of the rectum, lying 2 to 3 centimeter in front and slightly below the tip of the coccyx. Here, the ampulla of the rectum suddenly narrows down and pierces the pelvic diaphragm. In males, this is corresponding to the level of the apex of the prostate. The anus is the surface opening of the anal canal situated about 4 centimeter below and in front of the tip of the coccyx in the cleft between the two buttocks. The surrounding skin is pigmented and thrown into radiating folds containing a ring of large apocrine glands. Relations of the anal canal. Anteriorly, in both sexes, we have the perineal body. In males, the membranous part of the urethra and the bulb of the penis. In females, the lower end of the vagina. Posteriorly, we have the anococcygeal ligament over here and the tip of the coccyx. Laterally, we have the ischioanal fossae, and all around the anal canal is surrounded by sphincteric muscles, the tone of which keeps this canal closed. Coming to the interior of the anal canal, it is divided into three parts. The upper part over here, about 15 millimeter long. The middle part over here, about 15 millimeter long, and the lowest part, about 8 millimeter long. Now, each part is lined by characteristic epithelium and reacts differently to various diseases of this region. Here you can see this is the first part, this is the second part, and this is your third part. Coming to the upper mucus part, first part over here, this part, about 15 millimeter long, lined by mucous membrane, and this is of endodermal origin. The mucous membrane shows 6 to 10 vertical columns of folds. These folds are called the anal columns of Morgagni, and that these columns contain the radicals of the superior rectal vein. Now, the lower end of these anal columns are united with each other by short transverse folds of mucous membrane called the anal valve. This is the anal valve over here. Above each anal valve, there is a depression of the mucus which is called the anal sinus. The anal valves over here together form a transverse line that runs all around the anal canal. This is called the pectinate or the dentate line, situated opposite the middle of the internal anal sphincter here, and it is the junction of the endodermal and the ectodermal parts of the anal canal. Occasionally, the anal valves show epithelial projections called the anal papilla. These papilla are nothing but the remnants of the embryonic anal membrane. The anal sinuses contain the anal glands. The secretion of these glands produce a peculiar smell which is important in lower animals to attract. Coming to the middle part or the transition zone or the pectin, this is also 15 millimeter long and lined by mucous membrane but devoid of anal columns. The mucosa here is slightly bluish in appearance because of the dense venous plexus that is lying between it and the muscle coat. The mucosa is less mobile over here than the upper part of the anal canal. So this zone is also referred to as the pectin or the transition zone. The lower limit of the pectin often has a whitish appearance, because of which it is called the white line of Hilton, which is situated at the level of the interval between the subcutaneous part of the external anal sphincter and the lower border of the internal anal sphincter. This is the white line of Hilton. This is the lower border of the internal anal sphincter, and this is the subcutaneous part of the external anal sphincter. Now, the white line of Hilton is basically marking the lower limit of pectin or stratified squamous epithelium, which is thin, pale, glossy, and devoid of sweat glands. Now, coming to the lower cutaneous part, about 8 mm and lined by true skin containing the sebaceous glands. The epithelium of the lowest part resembles that of the pigmented skin, in which we have the sebaceous gland, sweat glands, and hair are also present. Now, coming to the anal sphincters, we have the internal anal sphincter and the external one guarding the anal canal. The internal anal sphincter is involuntary in nature, formed by thickened muscular circular coat, and it is surrounding the upper 3/4 or 30 mm of the anal canal, extending from the upper end of the canal to the white line of Hilton. Here you can see this is your internal anal sphincter, this is your external anal sphincter. What is this intervening? We'll do further on. Now, the external anal sphincter is voluntary in control, okay, made up of striated muscle supplied by the inferior rectal nerve and the perineal branch of the fourth sacral nerve, surrounding the whole length of the anal canal, and has three parts: subcutaneous, superficial, and the deep part. Contrary to the earlier view, the external anal sphincter forms a single functional and anatomic entity. The uppermost fibers blending with the puborectalis muscle. You remember the puborectalis was a sling surrounding the rectal opening, surrounding the rectum, part of pubococcygeus. This is it, puborectalis. So anteriorly, some fibers decussate with the superficial transverse peroneal muscle, and the posterior fibers are attached to the anococcygeal raphe. Here. The middle fibers, this is the external anal sphincter over here. Okay. The middle fibers surround the lower part of the internal anal sphincter attached to the perineal body, you can see over here anteriorly, and to the coccyx via the anococcygeal ligament. Now, some fibers also decussate to form a commissure in the midline. The lower fibers lie below the level of the internal anal sphincter and separated from the anal epithelium by submucosa. In the females, the puborectalis muscle, this is your puborectalis muscle, is separate from the external anal sphincter. This is your external anal sphincter here, and puborectalis, they are separate muscles. The anterior portion is thinner and shorter. In addition, in females, the transverse peroneal muscles over here and the bulbospongiosus muscle are fusing with the external anal sphincter in the lower part of the perineum. Okay, here. Can you see? The bulbospongiosus, the transverse peroneal muscle, fusing with the external anal sphincter in the female. In males, the transverse peroneal muscle, the bulbospongiosus, ends in the central point in the perineum so that there is a surgical plane of cleavage between the urogenital triangle and the anal triangle. So there is no merging of muscles. There is a separate surgical plane of cleavage between the two triangles in case of males. So coming to the longitudinal conjoint coat of the anal canal, formed by the fusion of the puborectalis. See this, puborectalis with the longitudinal muscle coat of the rectum at the anorectal junction. Okay. So the puborectalis was a part of levator ani. If you see the diagram over here, this is your sigmoid colon. This is the rectum. Then we have here is your pelvic diaphragm. The anal canal is piercing the pelvic diaphragm, right? So this is the puborectalis component of the pelvic diaphragm. So this is fusing with the longitudinal muscle coat of the rectum at the anorectal junction, forming the conjoint longitudinal muscle coat. And this is what is lying between the two anal sphincters, the longitudinal muscle coat. Okay. When it traced downwards, it is becoming fibroelastic, and at the level of the white line of Hilton, it is breaking up into a number of fibroelastic septa. Can you see over here? Which spread out fan-wise, piercing the subcutaneous part of the external sphincter and getting attached to the skin around the anus, called the corrugator cutis ani. So the most lateral aspect of the septa is forming the perianal fascia. The most medial septum forms the anal intermuscular septum, which is attached to the white line. In addition, this is the anal intermuscular septum over here. Okay. In addition, some strands pass obliquely through the internal anal sphincter and ending in the submucosa below the anal valve. Right. Coming to the anorectal ring, it is a muscular ring present at the anorectal junction, formed by the fusion, can you see over here, of the puborectalis and the uppermost fibers of the external anal sphincter, right? This is formed by the fusion over here. Here, can you see this is the puborectalis muscle? This is the puborectalis muscle component of pubococcygeus blending with the rectum over here, forming the anorectal junction. Easily felt on a per rectal examination of and surgical division of this ring will result in rectal incontinence. The ring is less marked anteriorly, as you can see, where the fibers of puborectalis are absent. It is basically posteriorly placed. Now, the surgical spaces related to the anal canal, you all are aware about the ischioanal space. Let's not go too much into detail of that. We've already done it many times. The perianal space surrounding the anal canal, containing lower fibers of the external sphincter, the rectal venous plexus, and the terminal branches of the inferior rectal vessels and nerves. Now, pus in this area spreads through transfer to the anal canal into the ischioanal skin. The submucous space of the canal above the white line between the mucous membrane and the internal sphincter contains the internal rectal venous plexus and the lymphatics. Okay, between the mucous membrane and the internal anal sphincter. Very important, arterial supply of the anal canal. Now, part of the anal canal above the pectinate line supplied by the superior rectal artery, and the part below the pectinate line supplied by the inferior rectal artery. Inferior rectal artery is a branch of the internal pudendal artery, and the superior rectal artery is coming from inferior mesenteric artery. Very important, venous drainage. It is in form of two plexuses. First one being the internal rectal venous plexus or the hemorrhoidal plexus lying in the submucosa of the anal canal. Here, draining basically into the superior rectal vein. This is superior rectal vein, communicating freely with the external plexus, with the middle and the inferior rectal vein. The internal plexus, therefore, an important site of communication between the portal system and the caval or the systemic veins. The internal plexus is forming a series of dilated pouches connected by transverse branches all around the anal canal. Now, the veins are the three anal columns situated at the 3 o'clock, 7 o'clock, and the 11 o'clock positions, as seen in lithotomy positions, are large and constitute the potential sites for the formation of primary internal piles. Very, very important. Whereas the external rectal plexus lies outside the muscular coat of the rectum and the anal canal and communicates freely with the internal plexus. The lower part of the external plexus is drained by the inferior rectal nerve vein into the internal pudendal vein, the middle part by the middle rectal vein into the internal iliac vein, and the upper part by the superior rectal nerve, which continues as the inferior mesenteric vein. The anal veins are arranged radially around the anal margin communicate with the internal rectal plexus and with the inferior rectal veins. Now, excessive straining during defecation may rupture one of these veins, forming a subcutaneous perianal hematoma known as the external piles. Coming to the lymphatic drainage, lymph vessels above the pectinate line drain while those into the with those into the rectum into the internal iliac nodes, whereas vessels from below the pectinate line are draining into the superficial inguinal lymph nodes. The pectinate line is forming a watershed line for the anal canal. Coming to the nerve supply, above the pectinate line, the anal canal is supplied by the autonomic nerves. The sympathetic nerves, that is coming from the inferior hypogastric plexus, the parasympathetic nerves or the pelvic splanchnic nerves, pain sensation carried by both of them. Below the pectinate line, supplied by somatic nerve, that is the inferior rectal nerve S234. So coming to the sphincters, the internal sphincter is made to contract by sympathetic nerves and relax by parasympathetic nerves, whereas the external sphincter is supplied by the inferior rectal nerve and by the perineal branch of the fourth sacral nerve. Now, very important, what are piles or hemorrhoids? We have the internal hemorrhoid and the external hemorrhoid. The internal piles or true piles are basically saccular dilatations of the internal rectal venous plexus occurring above the pectinate line, and therefore they are painless. But they bleed profusely during straining at stool. So, as we have done before, the primary piles are occurring in 3 o'clock, 7 o'clock, and 11 o'clock positions in the anal wall when viewed from the lithotomy position, formed by enlargement of three main radicals of the superior rectal vein, which lie in the anal column, occupy the left lateral, right posterior, and the right anterior positions. Varicosities and the other positions are termed as the secondary piles. Now, the factors responsible for causing internal piles firstly are poor support to the veins from the surrounding loose connective tissue, could be because of increased blood pressure, absence of valves in the superior rectal and the portal veins, compression of the veins at the sites where they are piercing the muscular coat of the rectum, direct transmission of increased portal pressure at the portosystemic communication. For these reasons, constipation, prolonged standing, excessive straining at stool, and portal hypertension are all factors causing or favoring the development of piles. What are external piles or false piles? Occur below the pectinate line and therefore they are very, very painful, but they do not bleed on straining at stool. Now, what is fissure in ano? Anal fissure is caused by the rupture of one of the anal valve, usually by the passage of the dry hard stool in a constipated person. Each valve is lined with mucous membrane above and with the skin below. Because of the involvement of the skin, this condition becomes extremely painful and marked by and associated with marked spasm of the anal sphincters. So, what is fistula? We've all done this before. Fistula is an abnormal epithelialized tract with connecting two cavities, one cavity with the exterior. Fistula in ano caused by spontaneous rupture of an abscess of around the anus and may follow surgical drainage. So most of these abscesses are formed by the small vestigial gland opening into the anal sinus. Such an anorectal abscess can take various directions, as you can see over here, opening medially into the anal sinus, laterally into the ischioanal fossa, inferiorly at the surface, or superiorly to the rectum. The fistula can also be ischioanal or the pelvirectal abscess. Fistula is said to be complete when opens both internally into the lumen of the gut and externally at the surface. Okay, this one. Now we have certain anorectal malformations such as the anal stenosis or the anal agenesis without a fistula. Okay, this is no anal opening. This is one of the anorectal malformation. Anorectal agenesis with or without fistula. Most of the anorectal malformation are caused by the abnormal partitioning of the cloaca by the urorectal septum. Now, just comparison of the upper and lower part of the anal canal developmentally, upper part developing from the hindgut or the endoderm, lower part from the proctoderm or the ectoderm. Now lining epithelium, upper part simple columnar epithelium, lower part stratified columnar and stratified squamous, arterial supply, upper part basically superior rectal, lower part inferior rectal. Venous drainage, upper part chiefly into portal vein, lower into the systemic veins. Lymphatic drainage, upper basically into the internal iliac lymph nodes and lower part into superficial inguinal lymph nodes. Nerve supply, autonomic nerves, sympathetic, parasympathetic, and the lower part by the inferior rectal nerve. Sorry, this is being typed in wrongly. It is sensory to ischemia, distension, spasm, upper part, lower part sensitive to pain, touch, temperature, pressure, and the bile of the upper part are internal, painless, whereas for lower is external. Little bit about the development of the rectum and the anal canal. The distal part of the hindgut is called the cloaca, divided by this urorectal septum into a primitive anorectal canal posteriorly and anteriorly by the vesico-urethral canal. The primitive anorectal canal forms the lower part of the rectum and the proximal part of the anal canal. Distal part of the anal canal is formed by the proctodium. Upper part of the rectum, that is part above the third transverse fold of the rectum, develops from endoderm of the hindgut. This part related to the peritoneum. The lower part, that is below the third transverse fold, is formed by the dorsal part of the cloaca, devoid of peritoneum. The anal canal, the upper 15 mm is developing from the primitive anorectal canal. The lower part below the pectinate line formed by the ectodermal invagination called the proctodium, and non-continuity of the two parts are resulting in imperforate anus. So that's all about the rectum and the anal canal. Thank you.